At the 50th annual meeting of the American Society of Hematology in San Francisco, this is Bob Finn reporting for the Elsevier Global Medical Network. Patients with chronic lymphocytic leukemia benefit when rituximab, a monoclonal antibody, is added to standard chemotherapy. This immunochemotherapy, or FCR as it's called, has now been tested in 2 large, randomized, placebo-controlled trials. Dr. Tadeusz Robak of the Medical University of Łódź, Poland, conducted a study of 552 patients with CLL who had already failed first-line treatment. Dr. Robak spoke at a press briefing.
Before, we obtained significantly higher percentage of complete remissions and overall remissions in patients treated with fludarabine, cyclophosphamide, and rituximab. The difference was statistically significant and translated into prolongation of progression-free survival in patients treated with FCR. The duration of progression-free survival, primary endpoint of the study, was 10 months longer in patients treated with rituximab combined with fludarabine and cyclophosphamide.
And Dr. Michael Hallek of the University of Cologne, Germany, conducted a study of 817 patients with CLL who had never before received treatment.
We recruited in a randomized phase 3 trial more than 800 patients in more than 100 sites in 11 countries, and found that FCR is more efficacious than FC in terms of higher complete remission rates and a longer progression-free survival, so time to progression. Also, the overall response rate was a little higher for the FCR, so it's more efficacious. Next, the important question is it safe enough? Because if you add one component, it could become a more toxic drug or drug combination. And yes, we found more neutropenias, so the combination caused a little bit more side effects in terms of the white blood cell count going down, but it was to an extent which could be safely managed because we saw not more infections in the two arms, and even more importantly, in the patients older than 70 years, we did not see an increased rate of severe infectious complications when we added the antibody. So in other words, it seems to be more efficacious, it prolongs the time to progression, and it is a safe treatment that can be given even to patients older than 70 years.
Now, is this a clinically significant result in addition to a statistically significant result?
The results are clinically very significant because if you have physically fit patients with CLL who need treatment, you now have a treatment combination that is prolonging the time to the next treatment by about a year, and we expect that with a longer follow-up this time will even increase. Data that we have from phase 2 trials show that after the first treatment, the usual time to progression after FCR is between 5 to 6 or 7 years. So it's a clear benefit, and this trial demonstrates for the first time that patients have a new treatment option. Patients with CLL have a new treatment option that is more efficient than the former treatment.
Is this the new standard of care?
With a note of caution, because I'm generally never assuming that clinical work is so, or our studies are so important that one can say this. Yes, I would clearly say if these data become public on Monday, they will change medical practice, and FCR is very likely becoming the new standard first-line treatment for CLL patients.
For the Elsevier Global Medical Network, this is Bob Finn.